Good evening, everyone. I'm Hebzi, representing Science Integra, and I extend a warm welcome to all of you to the 28th webinar of Maha Smile, Cleft Care for Every Child. This event is organized by MOX in collaboration with Smile Train India and the Public Awareness Committee of FOXY, with the aim of raising awareness about cleft lip and palate conditions in children.
अहो,
Over to
इतके
you, Dr.
नवराबायकोचे
Monica.
नमुने आहेत. आता तोच सांगायला बरं का मला त्यांनीच सांगितलं. ते टेम्पोचं सामान केलं त्याचे 5,000 रुपये काहीतरी गेले उसने घेऊन ते दिले. मग ते
Can you
नंतर
please
अजून
mute
येणार होते
rest
काहीतरी.
of the people, FZ,
त्यातले
because you are
ह्यांनी
only
Yeah.
the
2-3
host
हजार
right
रुपये
now.
बाहेर जेवायला घातले त्या दिवशी.
Yes, ma'am.
Yeah.
I'll just share the inauguration slide.
A very warm welcome to all the esteemed faculty members to the season 3, episode number 28 of Smile Train webinar series. This is a focused initiative which was started in Mouse around 4 years back under the able leadership of Dr. Padeshi sir and Dr. Kiran Koti sir and Dr. Bipin Pandit sir, that we have been consistently doing these webinars. The aim is to raise awareness regarding cleft lip, cleft palate, and the difficulties that the parents and the child faces, and the operative procedures, and where we have to refer these patients to. So today, let us evoke the blessings of Lord Almighty. And we are blessed to have Dr. Kiran Koti sir as our chief guest for today, and Dr. Rohini Deshpande madam, Vice President of AMOX, as our guest of honor. Thank you, Epsi. I would now request you to please share the slides. I invite our chief guest, Dr. Kiran Koti, sir. Sir, thank you for allowing us to conduct the program under the AMOX banner with me and Dr. Supriya Arwari, madam. Sir is the current president of AMOX. Sir has been the past chairperson of the MTP committee of FOXY. And over to you, sir, for
Monica,
the
it's okay.
words of
It's
wisdom.
okay.
Yes, sir.
Yeah.
Yes, sir.
At the
Thank
outset,
you.
I would like to have a big shout out to Monica and, of course, the Smile Train team, because Monica, you have been consistent and you have been instrumental in inviting this particular webinar on the Amox platform. And I think this is the 28th webinar which is going on. Am I right?
Yes, sir.
Fantastic. So that's really a fantastic initiative. So big shout out to you. And most likely this will be my last webinar as the president of AMOX as I finish my tenure shortly. And Monica, really a nice initiative by you. And of course, as far as Smile Train is concerned, it's a fantastic and noble initiative. And to enlighten people on the issues of cleft lip and cleft palate. And we have had a galaxy of speakers. I mean, I have witnessed to probably dentists, cosmetologists, facial-maxillary surgeons, sonologists, and everyone. And you're doing a fantastic job. My best wishes to you, Monica. And of course, today I
Thank you,
look
sir.
forward to hearing from all the faculties and a warm welcome. Of course, I can see Dr. Geeta, Sharad, Supriya, and everyone, Dr. Rohini, Dr. Sangeeta, and everyone. So, my warm regards from Amos to all of you. And of course, I hope, wish, and pray that this particular effort by Science Integra as well as the Smile Train, it continues in the next 2 years to come also. So my best wishes again. And as I sign off right now I'm at Hisar, Ahmedabad. So Monica, at a short notice, have joined. So thank you again for reminding me that this will be my last webinar as the chief guest. So thank you so much. Thank you so much on that behalf. Thank you. And my best wishes to you and of course to the Smile Train initiative.
Thank you so much, sir. It is always an honor to share the platform, and it is very heartwarming that you encourage all of us to get the best potential out of all of us, sir. Thank you. Thank you so much, sir. I would now introduce our guest of honor, Dr. Rohini Deshpande, madam, who has been the past president of AMOX. She is my mentor in AMOX. Madam has also been the past president and the founder secretary of the Solapur OBGY Society. And madam is an
Okay,
actively
Monica.
yes, ma'am. Ma'am, over to you for
Yes,
your
Monica,
blessing.
good evening. Yeah. Thank you very much, Dr. Monica and Dr. Supriya, for doing such a good work. And I heartily congratulate Dr. Kiran Koti for taking this initiative up and, spreading the awareness on this cleft lip and cleft palate. It's really fantastic. The teamwork is going on very smooth. This topic by itself is very huge topic, and it involves a lot of disciplinaries. And today's topic also is very important, that is medico legal aspect of this, and also the counseling of parents. So I really appreciate Dr. Monica and the team for taking a lead in throwing a lot of awareness on this subject. I wish you all the best, Monica, and you are doing a wonderful work. Best wishes. Thank you.
Thank you, ma'am.
Monica,
Thank you, ma'am.
Monica, I'll just interject. I can see my close friend, Dr. Rajendra Nehte. He is my senior from BC Medical College, a fantastic plastic surgeon. Hi, Rajendra, and good to see you
Hi.
here at Amos platform. So really,
Hi,
thank you for
Kiran.
being here with us.
Hi, Kiran. How are you?
Yes.
Yes, doing fantastic, sir.
Thank you for inviting me.
Sir is our second speaker for today, sir.
Yeah, I know.
Yes.
I
Thank
think
you.
Pandit sir has not joined.
Yes,
Hello.
ma'am.
Yeah.
Good evening, madam.
So, yes.
Good
Monica,
So-
only my request is, if you can keep the timing of these beautiful seminars, maybe sometime in the evening, that would be nice, so that, we can be there for whole
Sure,
of the seminar. Yeah,
okay, ma'am. Definitely.
thank you.
Thank you, ma'am. Thank you for the suggestion.
Uh,
So
I
since
now
this is
declare that the
my
inauguration is
job is
yes.
sorted, I think. So we can directly hand over to the MOC. But even I would like to thank Dr. Kiran Kurtakoti, Dr. Pandit sir, Rohini ma'am, all seniors of AMOGS who have, continued this initiative and especially the Smile Train team that has been consistently working, in tandem with AMOGS. And I'm really, really hoping that we can continue this movement. And already the Foxy leaders have shown the positivity in bringing this moment to the Foxy platform also.
So,
Thank you so much. And I think
Great,
now we
Supriya.
can hand over to Dr. Madan Kamble, who is MOC for today. He's the past president of the Akluz OBGYN Society. Currently, he's the national coordinator of Sexual Health Medicine Committee of Foxy. And very soon, we want to see him as the chairperson of Foxy Sexual Health Committee. So welcome, Madan. All the very best.
Yes.
And over to you.
धन्यवाद सुप्रिया ताई. धन्यवाद. Yeah, glad to be in the Smile Train. Yes, thank you so much, all the dignitaries and Dr. Supriya. Let us move forward to the scientific session. May I have the CV of chairpersons? Yeah, we have got the eminent chairpersons, Dr. Geeta Valsarkar ma'am and Dr. Sandeep Nikhade. Yes, Dr. Geeta ma'am is the past editor of Jogi and president-elect of Mumbai Obs and Gynae Society. And Dr. Sandeep Nikhade is a dear friend and past president of Nagpur OBGY Society, a fantastic endoscopic surgeon. I welcome both the chairpersons to this dais, and dais is yours. Please introduce our speaker. Over to you, Dr. Sandeep.
Geeta ma'am, please introduce our first speaker, and Dr. Sandeep will be.
Can
Yes,
I have biodata of Dr. Sharad?
Hebzi, can you please move the slides? Yeah.
Yeah. Thank you, Monica. Congratulations for having done about 28 webinars. But one suggestion I had, that if we have some form of data, or if we can collect some form of data, or the amount of audience we have reached, some data, some numbers, then we will be able to see where we are going or which direction we are going. So this is my suggestion. So now I introduce Dr. Sharad Shinde. He is, of course, a student from, say, GS Medical College and KEM Hospital. and is the director of Dwarka Hospital and Maternity Home with fetal medicine specialty. He is obstetrician with specialization in fetal medicine, FMF certified sonologist for fetal abnormalities and nuchal scan and Doppler. He has done invasive procedure course at BFMC Bangalore and done advanced ultrasound courses in various centers. He is the first obstetrician in Bede to have done advanced fetal 2D echo course at Amrita Institute in Kochi, represented as faculty in various regional, state and national conferences, and first center in Bede for advanced treatment for infertility, BOH, and high-risk pregnancy. Special interest in medico-legal issues related to obstetrics and fetal medicine. He is almost in practice since the last 20 years. The Secretary of the Association of Fetal Medicine Consultants in Maharashtra and the Secretary of the Bede Obstetrics and Gynecology Society. So, Dr. Sharad Shinde, you can start your talk.
Thank you, Geeta madam, for a kind introduction. Thank you, Monica madam and Kiran sir, for giving this opportunity to present this webinar on this AMOX platform. Today's my topic is the medical legal aspect of missing out anomalies, especially focus on the non-lethal ones. It is a very important topics. So what is the non-lethal anomaly? Definition is the congenital, structural or the functional birth defects that does not result in a death during the prenatal or immediate neonatal period. These conditions
Are you muted, Sharad?
just one technical problem is there. Okay. So these conditions may cause the physical or intellectual impairments, and they often allows the survival with the treatment or the corrections. Why not moving? My slide is moving or not moving?
Not moving.
Okay.
No, sir, it's
First,
not
It's
moving.
on the first slide, yes.
Just I will be top share and I will share here again.
Share again.
Yes, sir, you can reshare your screen.
It's not moving.
Dr. Sharad, can I give a suggestion?
Yeah.
Just go to the screen on the left hand lower corner.
Okay.
Do you find this thing triangle out there which advances the slide? Yeah.
Yeah. It is now. Thank you, sir.
Now it will work on your this thing. Okay.
Yeah, I will start from the first side. The non-lethal anomalies, this is the definition is the congenital or structural or the functional birth defects that does not result in a death during the prenatal or immediate neonatal period. This condition may cause the physical or intellectual impairments, and they often allows the survival with the treatment or the corrections. So because of that, for the medical legal issues, these anomalies, non-lethal anomalies are very important. So focus on non-lethal anomalies are why important as far as concerned with the medical legal implication. It is because they are often heightened for the non-lethal conditions because the child survives and has a lifelong need leading to the significant financial claim for the long-term care. And the pursued non-lethal nature is less relevant than the impact on the quality of life and associated ongoing cost, which forms the basis for the compensation in a successful lawsuit. So what is the detection rate? This is a 2020 systemic review meta-analysis data, but I think in 2025 it might be improved. In low and middle income countries, the reported that although the 90.7% pregnant women in SCR received at least one ultrasound, but the detection rates of the median anomaly detection rates is just 34.7%, and in low economic countries like Africa, it is just around 16 to 17%. So non-lethal, commonly missed non-lethal anomalies with the potential legal implications. I just go through this non-lethal anomalies from brain to toe. Usually these non-lethal anomalies, they are most of the times isolated. If they are not isolated and associated with other things, they might be a genetic cause and they become the non-lethals. For the brain, the non-lethals are the mild ventriculomegaly, arachnoid cyst, black pouch cyst, choroid plexus cyst, microcephaly, megacystoma magna, and corpus callosum agenesis. It might be partial or the complete when there is isolated. These are some videos of mild ventriculomegaly, then choroid plexus cyst, arachnoid cyst, and black pouch cyst. These are the isolated brain anomalies which are the non-lethal most of the times, but sometimes they might be associated with the lethal when the genetic syndrome is there. These are isolated ventriculomegaly, first image. Second image is isolated agenesis, corpus callosum agenesis. And third is mild ventriculomegaly with agenesis, partial agenesis of the corpus callosum. So these are also non-lethal isolated anomalies. In spine, the non-lethal, there are only two hemivertebra and open spina bifida. The hemivertebra is a correctable non-lethal anomalies when it is isolated, and even a mild form of or occult form of the spina bifida, it also a correctable anomaly and it is a non-lethal anomaly. In face, isolated non-lethal, most of the facial anomalies, they are associated with the syndromes. But when they are present isolated, they are non-lethal. And here I appreciate the SMILE train program of the AMOX because it is a great program for these patients for the isolated facial clefts. And facial clefts is the one of the non-lethal facial anomaly. These are some videos where the detection is very important for the facial anomalies. Proper coronal and sagittal planes or the views are very important. And there are high chances of missing facial anomalies. And this baby also appreciates the SMILE train programs. He's saluting you for the AMOX platform for giving this opportunity to serve for the facial clefts anomalies. However, the isolated cleft palates confirmed entirely to the oral cavity, it remains notoriously difficult to identify prenatally, even in an expert hand and high technology. Even high technology is available there. So this is very important, and this is much more troublesome for the families because it also have the cosmetic impacts on the babies. So in neck, non-lethal nuchal edema and thyroid goiter. Nuchal edema is not an anomaly, but it is a marker. But it is a marker for the hidden non-lethal genetic syndromes, and especially for the trisomy 21. The nuchal edema in first trimester we have to measure back of the neck, and in second trimester it is the back of the head. If it is properly measured, it is an indicator or one of the soft markers for the hidden non-lethal aneuploidies, and especially the trisomy 21. Second thing is goiter. This is also a non-lethal. Most of the times it misses. Thorax. In thorax, most of the times the lung non-lethal anomalies are there and they are isolated. Bronchial cyst, CPAM, diaphragmatic hernia, pleural effusion, and pulmonary sequestration. These are the few videos of bronchogenic cyst. This is correctable and it has a treatment postnatally. Again, pulmonary sequestration and diaphragmatic hernia. If it is diagnosed at proper time and intervene at the proper time, it might be saved the baby's life. In heart, there are so many non-lethals if they are isolated, but detection rate are very low, and sometimes these are the few anomalies, non-lethal anomalies, the sonologist can miss. First is the VHD, isolated small VHDs, DORB, double outlet and the top. These are the non-isolated when they are the presented isolatedly. In congenital heart defects like TGA, also correctable anomaly, but they found that even with the targeted outflow tracks, the detection of TGA improved from only the 15.7 to 41% over the decade. But nowadays, because of the highly trained fetal medicine units, the detection rate goes for the 70 to 85%. And this is one of the non-lethal correctable anomaly postnatally. I'm not going in detail with the lethal anomalies. In abdominal wall, there are the two anomalies, that is the gastrochiasis and congenital umbilical hernia. They are detected easily, and gastrochiasis is the non-lethal because it is most of the times not related with the genetic cause. And if it is detected and intervened at right time, it might be correctable. Then gastrointestinal tract, non-lethal there are so many, 3 atregias, that is anorectal, duodenal, esophageal, and abdominal cyst and esophageal duplications, and so many calcification, Spreng's disease, and tumors, non-usable gallbladder, and small bowel obstruction. These are the, if they are isolated and pick early, they are the non-lethal conditions. But remember that the gastrointestinal atresia and obstructions, the prenatal detection of gastrointestinal anomalies relies heavily on the indirect signs that are the polyhydramnios or dilated bowels, and which may present in the later stage of the pregnancy, and there are high chances of the missing these anomalies. In case duodenal atresia, sometimes the double bubble signs is the classical sign for detection, but sometimes it is not present, only the enlarged stomach bubble present, and that there are high chances of missing this anomaly. And in esophageal atresia, same thing. Sometimes the presence of small and intermittently visible stomach may interpret the presence of the normal, and chances of missing the esophageal atresia is there. Even H type of tracheoesophageal fistula, same thing happen. The missing chances of the esophageal atresia is high. These are the 3 videos for the atresia cases. First is esophageal atresia. There is a collapsed stomach. Second is double bubble sign for duodenal atresia, and some indirect signs for the anorectal atresia. And anorectal atresia is usually the suspected diagnosis. Is very difficult to diagnose prenatally. Urinary tract. There are so many things, but the hydronephrosis and multicystic dysplastic kidney, these are the 2 conditions which usually present, and they are in a non-lethal form. If they progress, they become the lethal cases. These are the 2 videos of the hydronephrosis, mild hydronephrosis, and multicystic kidneys. Again, a genital tract. The genital tract anomalies, non-lethal anomalies, very difficult to diagnose, and most of the times people are not giving seeing these anomalies because of that PCP acts. And there is a hypopaedis, which is a commonly missed non-lethal anomalies. This is video of the hypopaedis. In genital tract anomalies, the hypopaedis, where there is a tulip signs. If typical tulip signs is there, there are chances of the diagnosis. But in India, the legal restrictions under the PCP Act further discourage the detailed evaluations and reporting of the fetal genitalia. So there are the chances of missing the non-lethal anomalies in genital because of the strict PCP Act guidelines. In extremities, there are so many non-lethal anomalies of the extremities. When they are isolated, they are always non-lethal. But when they are associated with genetic syndromes, they might be lethal. And these are the 8-9 extremity anomalies, non-lethal anomalies. And these are the common CTAV, either it is unilateral or bilateral. This is a video of the club foot. These are the video of the club hand and polydactyly. When they are isolated, they are non-lethal, always non-lethal. So limb abnormalities, prenatal ultrasound remain the primary modalities for identifying the fetal limb abnormalities, and its diagnosis accuracy is limited by the anatomical, technical, and operator dependent factors. And last and most is a skeletal dysplasia, diagnostic complexity. Here also the high chances of missing. Some skeletal dysplasias are the non-lethal, and they are the achondroplasia, thantoporic dysplasia, and osteogenesis imperfecta, and are notoriously difficult to diagnose prenatally. With over the 350 genetic syndromes, they are associated with this, and accurate diagnosis often requires the molecular testing or the postnatal confirmations. And this, even with the best practice, many skeletal anomalies are detected only after the birth. And this is not indicative of poor care, but reflect the ultrasound inherent limitations. Krakow et al. Emphasized that ultrasound may suggest a skeletal abnormality, but cannot distinguish between the lethal from the non-lethal variants without further investigations. So most of the skeletal anomalies required the sonography with the genetic evaluation to label them as a lethal or non-lethal. So despite technology and advances in many congenital anomalies, particularly the cardiac, urogenitals, facial, limb, skeletal defects may go detected even under the optimal conditions, even with the advanced technology and advanced knowledge. So reason for missing non-lethal ones, why they are missing, even with technology and upgraded knowledges are there nowadays. This is just because lack of uniform screening programs, operator skill training variability, equipment disparities, maternal and fetal factors, delayed access to the prenatal care, and regulatory requirements of the PCP Acts. So in India, unlike many developed countries, in India, lack of nationwide standardized screening policies, mandating routine mid-trimester anomaly scan. Many women undergo ultrasound primary for the growth assessment or well-being check, not for the detailed anatomic survey. In rural and unserved areas, some women may only receive the late third trimester scan, by which time the detecting structural anomalies is far more difficult. Consequently, the anomalies are sometimes missed simply because of the appropriate scan was not done. This is a major reason for the missing the non-lethal anomalies. Second cause is operator skill and training variability. In India, it has a diverse range of ultrasound providers, including radiologists, obstetricians, general practitioners, with variable levels of the training in fetal imaging. Outside the tertiary centers, the anomaly scans are often performed by the clinician without specialized expertise in fetal medicine. And it is highlighted in multiple studies, the detection of subtle and complex anomalies depends heavily on the operator experience. Third reason is equipment disparities. Ultrasound technology varies widely across the India. Urban hospital may have the advanced techniques, 3D and 4D capabilities, while the smaller clinics may rely older one 2D devices, and many anomalies, especially the subtle ones like mild ventriculomegaly, spatial gaps, or small septal defects, require the resolution imaging to detect. And in medical legal evaluation, it is essential to consider the capabilities of the machine used, and a practitioner cannot be held accountable for the failing to diagnose findings that were required high resolution imaging to detect. This is one of the important practical points as far as the medical legal. The maternal and fetal factors. There are so many factors. If there is obesity, uterine scar, fibroids, or the even amniotic fluid, oligohydramnios and polyhydramnios significantly affect the ultrasound image quality. And in fetal positions such as cross arm, flex limb, or back-to-back postures, they can obscure the critical anatomy. So these factors also take into the consider, and these factors are beyond the critical controls. And in Indian, concluding one case, Sentinel Scan Center, the court also observed that the skilled practitioner may fail to visualize certain structures due to the unfavorable maternal and fetal factors. This is landmark judgment where that observation given by the courts. Delayed access in prenatal care. In many Indian women present late antenatal care due to the cultural, logistical, or socioeconomic factor. This is one of the factor for the late detection or non-detection of the non-lethal anomalies. Even if anomalies are detected late, option for the prenatal intervention or the legal termination may longer viable. And this is a systemic issue, not reflection to the physician error. Regulatory climates. PCPNDT had the lot of clerical and other paperwork is there, and because of there is a hesitations in the care obstetricians to do the scan or not. And there is a because of that there is a defensive attitude in the most of the sonologists. The non-lethals are important than lethal because these are the targeted first trimester. Even babies are few diagnosed, and anyone can with routine basic machines also anyone can diagnose. And lethal has not that much litigations or the legal allegations against the sonologists because they are diagnosed and people are easily accept. But what happens with the non-lethal anomalies? The key medical legal aspects are if failing to detect non-lethal fetal anomalies can lead to the significant medical legal challenges, primarily categorized as a wrongful birth. Liability hinges not on causing the conditions, but the physician failure to meet the standard of the care. It is very important whether physician meet the standard of care or not in a screening, diagnosis, or the communications, which deprives the parents of the opportunity to make an informed decision regarding the pregnancy, whether to continue or terminate. So the key medical legal aspects are there, whether causation or loss of opportunity to give the birth or not. In wrongful birth lawsuit, the claims is that doctor negligence caused a loss of opportunity to prevent the birth of a child with a disability, either by preventing conception or by legal termination. And these claims, wrongful life claims, the most of the times, these claims brought on behalf of the child have largely been unsuccessful in many jurisdictions just because court also struggles with quantifying the damage by comparing a life with disability to the state of not existence, and such a claims can be seen as a devaluing disabled lives. Now, what are the criteria for compensation and damages? If negligence proved, these are the 5 criteria: child lifelong care, medical expenses, equipment, rehabilitation, as well as the parental pain and suffering. These are the 5 criteria court will be considered when the negligence is proven. Now, what are the medical legal perspectives and court rulings in India? All the claims are not successful. Court also decides depending upon the certain factors and certain measures and certain facts they are used. Over the past decades, the medical legal implications of the miscongenital anomalies of the prenatal ultrasounds are increasingly relevant in India. And such cases are typically filed in the consumer courts as a claims of deficiency in services against the sonologist, obstetrician, and diagnostic center. So central legal issues, whether to failure to detect an anomaly constitute the breach of the standard of the care, whether that sonologist or diagnostic center is as per done the scan as per the standard of care or not. This can be observed by the courts. And this Bolam test is used in Indian courts. These Indian courts follow the Bolam test. It is derived from the English law, which stipulate that the doctor is not guilty of the negligence if their conduct aligns with that of the reasonably competent professionals in the same field. So this test is very important and courts follows in many of the cases. These are some principles reinforced with the Vinita Ashok versus Lakshmi Hospital in 2001, as well as the State of Punjab versus Shivram in 2005. Underscored the mistakes in the diagnosis do not automatically equate to the negligence unless the error was one no reasonable professional would commit. So court also see whether the negligence is proved or not proved and standard of the care is there or not. So again, this is landmark precedent. Court also use before giving any decision, using the previous citations or previous landmark judgments. This is one of the landmark judgment for the non-lethal anomalies, Sentinel Scan Center versus the Shanti Sridharan. Here in this case, there is the forearm reduction defects, and court observed that the ultrasound reports. The court observed that whether this anomaly is obviously this anomaly is how much time it is missed and whether it is diagnosed or not diagnosed. So this is a subtle type of diagnosis and whether it is caused by the environmental or genetic cause. This observation is made in this case. Then informed consent and legal protections, whether the patient is informed about the limitations of the scan or not. In this case, there is a one board disclaimer signed by the patients acknowledging that some fetal abnormalities might not be detected due to the technical limitations. And because of that disclaimers, this allegation is court has dismissed and given in favor of the doctors. So informed consent is very important as far as legal protection is concerned. Then role of the expert testimony. Always courts, most of the times court depends upon the expert testimony. Here is the Hemlata and Manoj Singh cases. In this case also the court observed that the ultrasound reports are not conclusive evidence on their own as they are not 100% accurate and must be interpreted with the clinical correlations. Then reformations. Here also this case is Dr. Manoj Singh with Srimati Renu. In this case, there is also the deformity of the lumbar spine and serum. The Manoj Singh's defense is that the referred hospital referred for patient for only the 2D ultrasound scan, and lumbar spines and sacrum anomalies are not diagnosed with the 2D. They require the 3D or 4D or MRI scan. And court accept their defense that ultrasound is not 100% conclusive and negligence must be proven from the expert opinion. So expert opinion is very important in such a negligence cases. PCP and Data Act. There is a clerical as well as the burden. If you have done a clerical mistakes and you have missed also the anomalies, that there should be a differently taken into granted or observation. Court nowadays observe for the clerical errors, there is no such a same punishment as that of missing the non-lethal anomalies. This is also a recent observations that doctor can't be held negligent for the missing anomaly caused due to the genital or the environmental factor. This is the one case where the case is referred, done multiple scan for the low-lying placenta and patient referred for the higher centers. And the patients sued in this center for this hospital for because of the referred for the false reason. But later on baby delivered with the absent forearm. So court taken into granted that this observation that giving birth with anomaly which amount to the medical negligence because said anomaly was caused only due to the genetical and the environmental factors. So this is very important observation. Nowadays court also think the missing anomaly is not a negligence. Okay, so if this is caused because of the genetical or the environmental factors, so you have to prove that reason is that. If you prove your defense is accepted by the court. So now the prevention. How will you prevent the medical legal risk mitigations in such a cases? If you prevent this by the proper documentation, communications, by giving standard care, expert opinion and guidelines, and follow the SEPS essential protocols that act applied for this thing, that is the PCPNDT Acts. So documentations. Maintain the meticulous record of all the scan, discussions, informed consent, and any maternal or fetal factor is there that obstructing the quality of the scan, you have to mention on your paper or in a disclaimer. So communication is also very important. So ensure the parent are fully informed with the inherent limitation of diagnostic test, and they should understand the distinction between the screening and the diagnostic testing. Expert opinion. Courts are heavily depends upon the expert testimony to determine if the standard of care was there or not. And also adhere your guidelines. Which guidelines you are following? Most of the sonologists, they are following the ISOS guidelines for the obstetric scans. Follow the essential protocol as per the Act. Fulfill the requirements, proper documentation, and do the all scan at proper gestation as per the guidelines. So what is standard care? Because this factor is very important. Court always see whether you are as per standard care or not. These are the 4 things about the standard care. First is that is given in the textbook, practice in the nearby medical college, practice accepted by peers, and appeared in any index journals. So this is very important for the legal defense, whether you proved or whether you are followed standard of care in this missing case or not. Informed consent. Physician has a legal and ethical obligation to counsel parents about the limitations of the prenatal screening test, potential risk and possibility of some anomalies may not be detected. A robust documented informed consent process, sometime including the signed disclaimers, they are very crucial for your defense in the courts. I usually use these disclaimers. When patient come for the early anomaly scan, I always counsel them that there are the limitation for the early limb scan, and they requires the detailed antenatal fetal to deco and neurosonography. If you have done the scan for the 16 to 18 weeks, and if there is a late anomaly scan, I always counsel patient that detailed anomaly survey is not possible at these gestations, and there are certain limitations because of these are the factors. Again, for the mention in your report and in disclaimers about the maternal factor and the fetal factors, they are also very important. And whatever you see, report that only. Don't report whatever not you see. And why these all documentation, consent, standard cares are important, and documentation, communication, and vice versa both is very important. Just because the reality of the courts is courts are not the courts of justice. Courts see only the evidences, and courts see only the things which are shown to them, and that is required on paper. So protective cover of the legislation, when you get in missing anomalies, you will get the protective covers of legislation only when you will fulfill the mentioned requirement completely as per the PCPNDT Acts, guidelines, and standard care. If you fulfill these things, you will get the protective cover of legislations. So documentation is a very critical physical defense. It is just because the good record, good defense, poor record, poor defense, no record, no defense. If you're not having any record, there is no defense. And doctors are very poor in record keeping. Now in courts, just 4 5 slides are there. In courts, the balance is balances depends upon the strong evidences, whether you prove how strong evidence is there. And in obstetric practice, the conclusion is that you need the balancing between the science, law, and patient's care, and it requires the teamwork. Now see, this is a demoralizing story in papers. This is just because they are not followed the standard cares, and they are reported what they are not seen. Because after the birth, there is a abnormalities in the fetal upper limb as well as lower limb. So always report only what you examine and avoid the habit of copy-paste reports. Then what are the facts? What codes are considered the facts? Medical science, despite its constant innovation, it is not perfect. The most modern medicines may not cure. The best diagnosis test could miss anomalies or abnormalities. Follow standard care protocol and accept report only from the center following this. Law accept this fact. It is simply mandates that the doctors keep patients well informed about such a shortcomings, and that may be depends upon one case to another. These are facts are very important. Now, these are some inspirational stories about the non-lethal one. This is the first one came to me for pre-marriage counseling of genetic work. His forearm is not there. And second is a farmer. He has given a birth in my hospital, this healthy child. And both are very happy because today's atmosphere, today's advanced sonography and all that thing, they might be not in this world. And this third case, Sean White, this is also inspirational case. This is two times Olympic gold medalist, and she is suffering from the tetralogy of Fallot's. And after the birth, the tetralogy of Fallot corrected, and she is now Olympic player. Now, all of you seen these two pictures also of Amir Khan. This is one. If you are not allowing these structural peoples, if there is no functional defects, then let them to come into this world. Also, this is Tare Jameen Pe. This is also having some genetic problems. And my take-home message is only single. Don't terminate all non-lethal anomalies, baby, if functionally not affected. If they are structurally affected, they can be corrected. So what? Let them come in this world, and just because we appreciate the Amox platform of that smile train, and this is very useful for this structurally affected babies. For functionally, it is not useful. And I finish my talk with this quote of Swami Vivekananda. All of you read. This is very applicable for the doctors. And thank you again, the Amox platform, giving me this opportunity to present this topic. Thank you.
Congratulations,
Thank you,
Sharad.
Sharad sir, for your wonderful presentation.
Congratulations,
Yeah,
Sharad, for very
requesting.
wonderful,
Yes.
insightful presentation. Hello, am I audible?
Thank you, sir. Yeah,
Yes, sir.
Yes,
You're
Sharad.
audible.
Dr. Sharad, I would like to ask you,
Yes,
what
yes,
is
you're
your
audible.
experience? What is your experience in the lawsuits? Whether that clinical diagnosis is missed or the communication to the parents is wrongly done?
Yeah, the most of the time as I saw, the parents are alleging they are not informed about the things. So most of the times the lawsuit is because of the lack of communications, and they are not properly counseled about what they are.
Yeah.
And few times the missing, usually missing non-lethals, that will happen if there is a subtle anomalies are there, like small VHDs, mild ventriculomegaly. But people will not go for the lawsuit for such things. But the communication error is the main cause for that.
Right. So we will never have a 100% detection rate, but we will have a 100% empathy rate. So it is always better to go for the more on the communication part. That is first giving the diagnosis to the parents and the legal heirs of the babies.
Yeah, I always counsel the patient after the anomaly report. The normal report means not 100% normal.
Right.
I'm giving an example. When they are traveling from the village to my hospital, the data will tell that there is a 10 to 15% chances of the accidents. Here also during the anomaly scan, there are the chances of 10%, 15% missing some anomalies, or there are some anomalies are the evolving.
Right. So 3 pillars of managing such outcomes is the honesty, empathy, and action.
Yes, sir. Absolutely.
Geeta ma'am?
Combined counseling with the neonatologist, with the pediatric surgeons or the required surgeons. The combined counseling goes a long way, in being, because we cannot tell them what will be the cost of the surgery or how will the child will perform after surgery. But if we have a combined counseling, they will be definitely able to give a better idea as to how. And in Vadia, we have a specialized Cleft clinic, and we have CTV clinic. We have specialized clinics like that, where such combined counseling is done between Jerbai and Navroz Jivadia.
Yeah, even in heart anomalies also, if parents want to continue that pregnancy, you have to counsel them prenatally with the pediatric surgeons.
Pediatric
So whenever there's
cardiologist.
need of other people postnatally, you always give them to approach to the that specific person or the specific centers. It will be help for that.
They should
Because
also come for counseling.
in high risk cases like in IVF conception, all that people want to continue with this non-lethal isolated anomalies, and in that cases it is very useful.
Can
And
I add one
documentation,
thing, Sharad sir,
evidences.
please?
If the medical legal issues happens now, you have the evidences with you. That nowadays the consents are there, disclaimers are there. So use the disclaimers and consents for that.
Or combined counseling, after doing, all of you can sign that they
Yeah,
have
yeah.
been informed so and so, and they have chosen to continue the pregnancy. So that is also a definite this in our favor.
Yeah. Preparing mind of the couple and their family is very important if you are diagnosed something or if you are miss something.
So what we generally see in a busy practice is that people give the prescription, but they don't keep an OPD paper with themselves. So when we do a counseling, it is ideally when we write on the prescription also that the counseling has been done, as well as on our OPD paper, because that is the only thing that we will be able to produce in the court of law, because prescriptions patient lose.
If you have done a software prescription, then take 2 prints out of that. If you are using handwritten, then use the carbon. I am using since last 20 years. This I'm keeping one copy with me. Also, I am keeping one report copy, last copy signed by the patients.
I have an entire OPD paper, sir, or
Yeah,
for
yeah,
every
yeah.
visit. So that documentation goes a long way in the court of law for as a defense. So thank you
Nowadays,
so much, Sharad sir.
verbal and implied
Yes.
consent is no useful. You have to keep the
Video
written
consent, sir.
documentation. Yeah.
Video consent is
Even
more
some people also started video consents.
in high-risk patients. When we are counseling regarding eclampsia, video consents are taken as an evidence in the court of law.
No,
sir.
and plus, especially in anomalies, we can draw. You know, if we give draw a diagram or like options, 2 options, I normally write in my own handwriting 2 options, 1 termination, 1 continuation. If continuation, then this. If you can draw diagrams, or even like from kidney, like the up to ureter, bladder. If we draw everything, that means we have tried explaining to the patient as in as detail as possible. So we should keep that with us, the counseling, when we counsel the patients.
Yes, absolutely.
Thank you, sir. Madan sir, can we introduce? Yeah, Sandeep sir, can we introduce our next speaker, sir? Yeah.
Yes,
Yes.
ma'am.
Please, can we have this CV slide?
FZ?
Yes.
Yes.
No, next one.
FZ, can we have sir's slide, please? Yeah. Thank you. Sandeep sir, it's on the screen.
Yes, yeah. So, good evening, everyone. Good evening, Monica madam. Good evening, Kiran Kortakoti sir, and for giving me this opportunity to chair this session. It's a very wonderful session and very important for counseling part of the parents is concerned. So we are having our next speaker, Dr. Rajendra Nahete, who is a plastic and cosmetic surgeon, who is the director of the Vedant Hospital, Nashik. He's also having a hospital for the plastic, cosmetic and hand orthopedic surgery. He's the project director for Smile Train, Vedant Hospital, Nashik. He got a fellowship in the hand surgery at Vedant Hospital from Maharashtra University of Health Sciences, Nashik. His present position includes trustee of the Indian Society of Reconstructive Microsurgery. He is the president of Brachial Plexus Surgery Group of India. He is the president of Maha Association of Plastic Surgeons. He is also EC member of World Society for Reconstructive Microsurgery. He is an ex-president of Asia Pacific Federation of Association of Reconstructive Microsurgery, Indian Society for Reconstructive Microsurgery, and Indian Society for Surgery of the Hand. So we are having a surgically expert person, Dr. Rajendra. The stage is yours. Rajendra sir.
Yeah, thank you, Dr. Sandeep, for this kind introduction. And I'm really thankful to Amox and SmileTrain for inviting me for this webinar. And for me, it is very important webinar because I would like to discuss about this SmileTrain project and what we do in SmileTrain project, because many times we don't have the inter-faculty coordination to a great extent. And I think this webinar is very important, and you accepted to get me here, and that is really a good opportunity for me. So I want to share screen desktop. Hey, Rajeshri.
Hebzi, please make
So
sure
you
the
will
co-host
have an
so that you
option
can
to
share.
share. Yeah.
Yeah, I am sharing it.
Okay.
There is some problem. Sorry, I was busy in surgery and
We can see your screen now.
you can see my screen?
Yes.
Yes, sir.
Okay, yeah.
Yeah.
Can you see my slide?
Yes. Yes.
Yes.
Yeah, thank you. And Chairperson, Dr. Geeta, Dr. Sandeep, the convener, I appreciate their efforts to go to public and to create this awareness. And Chief Guest, Dr. Kiran, my friend from BJ Medical College, and today's guest of honors, I welcome all. And this is about the first smile we give to the cleft lip and palate patients. Uh, so I will talk about perinatal counseling and surgical planning in cleft lip palate patient, and we will spend some time with the stories of cleft lip palate patients. So first of all, SmileTrain, what is SmileTrain? It is one of the largest cleft focus international organization and provides free cleft surgeries and comprehensive cleft care to children with cleft lip and palate. Over last 25 years, SmileTrain supported almost more than 2 million patients with safe, high quality and free cleft surgeries. So, scope of my talk will be the health problem because of cleft lip palate, what is SmileTrain project, the antenatal diagnosis in cleft lip palate, the counseling, surgical schedule, and what's the end result. So cleft, when we see such baby, it creates a major public health problem, a child born with the cleft. Because first of all, the mother starts crying because of the appearance of the child and whole family is under stress. There are speech concerns because in a speech apparatus, the lip and palate plays very important role, because if you consider that what we speak, the labial words are p, and these cannot be uttered properly. Only what they can utter properly is IE, because IE is, it comes from our vocal cords, and there is no role of lip or palate. But if you see, there is a cleft alveolus also. So we can't speak alveolar words like yara, lavasha, where we touch our tongue to the alveolus. When we touch our tongue to the palate, we speak ta, ta, da, da, na. All these words cannot be uttered. So in short, there are, if you consider the words what we speak, there are vowels and consonants. So vowels are directly from the vocal cords and they can be spoken very easily, which is A, E, I, O, U. Or in Marathi, what we say, A, I, E, O, Aha. But the consonants like ta, tha, da, da, na, pa, pha, ba, ba, ma. So only what they can speak is the vowels and not the consonants. They will be abnormalities and children can't speak properly. And then this, when they go to school, it leads to bullying in the school. And then there are self-esteem issues in these children. So there are academic struggles for these children because they can't speak properly. And they have poor marital prospects if the deformities remain on the face, if they can't speak properly. And then ultimately there are job related challenges. And if we can't give best of the result, one generation of this family suffers to such an extent that the whole family suffers out of this. So if we give a good surgery, that's one of the surgical result, and you can realize there are no marks even in this. So, but this happens in early childhood. When the child grows, there can be minimal scars. So this is another child, and we can give them beautiful results and a good smile. That is why the name is Smile Train. So smile is only the beginning. Access to a full range of comprehensive care gives children with clefts the best chance at a healthy and productive life. We'll come to that. So if we follow this child to adulthood, this is the early photograph, but this is the adult. So there are minimal marks on the cleft lip palate because this in the central of the lip, he doesn't have a hair, but we can do hair transplant for this patient and completely hide his scars also. Otherwise, he looks absolutely a normal child. This is the same patient which I operated many years back, and now he's a college going student. Whereas in rural, in tribal area, in an urban area, it is okay because the parents are oriented, they come. But in rural area, we see patients like this. This is girl from tribal area, and she came to us directly like this. And she was brought to hospital just because she couldn't get married with this deformity. So we operated her, and within 1 month, she was engaged, and we were very happy that she got married. So she came after marriage with her husband to see us, and she was extremely happy with this. But the problems are in rural areas, there is non-availability of surgical centers, there is non-uniformity of the results, there is non-standardized training of the surgeons as well as the paramedics, and there are socio-economic issues. So Smile Train is one which solves this. So Smile Train does, so we have social workers in the hospital who will locate these children. They go from school to school, they go to house, and they select these patients and bring. Smile Train also empowers the local medical professionals because Smile Train doesn't say that you bring our patients to a central area. So what Smile Train does, we are almost 70 centers in India, and all the surgeons are trained properly by Smile Train. They take responsibility for it. They even train the nutritionist, they train the orthodontist, they train the speech therapist, and that's how we call it a comprehensive care. And they provide really a good comprehensive care. So it is a great sustainable model, Smile Train India, which is part of international charity, and we are extremely happy to be part of it. So if you see the incidence of cleft lip palate worldwide is around 0.8 to 1.6 per 1,000 live births. In India, around 27,000 to 33,000 cleft births per year. And there are 3 infants are born every hour. So while we are in this webinar, there will be 3 cleft children will be born in India. See the magnitude of this problem. And all these children, if we want to take them to the 22nd century, and if we want to have a progress in India, I don't think we can keep these 30,000 children behind the other normal children. And that is why it is very important. Talking about the antenatal diagnosis, it is very important to diagnose them because nowadays, when the child is born, first thing is goes that whether any doctor has done a mistake. So it is our responsibility to diagnose them properly, counsel them properly, and let them know that they are going to have a boy or a girl with cleft lip and palate, or maybe only cleft lip. And but the prognosis now, whether the pregnancy can be carried forward or not, it will depend on type of cleft and the associated anomalies, because if they are major anomalies, then the child may not be fit to survive and it may just be aborted. But if they want to continue, then we have to take all the efforts. Now, I will not go into detail, but 2D ultrasound was not very good and was not very specific to diagnose because it had drawbacks like operator dependent, technique dependent. Also, there are a lot of problems like maternal body habitus, the amount of amniotic fluid, and the fetal position also, because on 2D, there are limitations. Whereas on 3D ultrasound, you can see this picture of a boy who was diagnosed in a antenatal diagnosis. And this was the family who brought them like this. This is a patient with left incomplete cleft lip and palate in our hospital. And then we counseled them and they continued the pregnancy. So 3D ultrasound has a high precision. It is almost confirmatory. You can do a volume reconstruction and you can have multiplanar views, and that's how it becomes more sensitive and specific investigation. You can have reverse face and flip face views, and it is possible for detection in the first trimester. So it is, I think all of you go for 3D ultrasound anomaly scan now. The MRI also has a role, but not being routinely used at present because of the radiation which will be given because it can really detect in first trimester. It has an improved accuracy, but not really useful in today's era. When we have an antenatal diagnosis, the picture is like this. The mother is trying to counsel the prospective mother, and the husband is looking at what is going to happen with our family. So parental counseling is very, very important, because we need to prepare these parents to adapt to the child born with the cleft, because there are few surgeries they will need. There will be special attention which will be required. And there are a lot of parental anxieties and concerns which we need to solve. We need to sit with them and discuss about the problem. So we have to provide them accurate and realistic information about the etiology, the feeding of the child from beginning, the treatment protocol, and pre and post surgical support in comprehensive manner. So if you talk about etiology, there are environmental factors like maternal exposure during early conception to either smoking, excess alcohol, viral infections. You know that the teratogenic medicines or chemicals like steroids, antiepileptic drugs like hydantin, that is phenytoin, sodium valproate, and there are few patients with poor nutrition who give birth to the anomalous child. Then there are genetic factors. Because of genetic mutation, it can occur. And there are syndromic clefts. I will not go into detail, but there are majority of them are isolated cleft palate, like in Treacher-Collins syndrome or Down syndrome or velocardiofacial syndrome. So it is when the child is born, immediately, it is the pediatrician's duty or neonatologist who will diagnose properly whether they are syndromic or not. There can be associated anomalies like head and neck ear anomalies. In the heart, there can be ASD or VSD. In the hand, there can be polydactyly or syndactyly. There can be hypospadias with cleft lip and palate. And there are some certain neural crest defects in cleft lip palate. Now, if you talk about genetic counseling, because most of the parents would be interested, will it occur in the second child? It is okay in this child, it has occurred, but will it occur in the second child? And we have positive family history in almost 17% of the cleft. And if you talk about risk of developing in the next child, then we have to talk to them properly. If there is a one sibling with cleft, already born with cleft, then there is 4.5 to 2.5 chance of having cleft lip or either a cleft palate. If there are two siblings born with cleft, then it is a 9% chance. It increases significantly. If there is a parent with cleft, then there is a 3.2 to 6.8% chance that child will have a cleft. And if there is one parent and one sibling, then there is a highest chance of having 15% chance of having cleft in the child. But there is no association with the extent of the cleft, because it can be incomplete cleft lip, it can be complete cleft lip, it can be complete cleft lip and palate. So there is no association, but there can be a cleft. So they need a psychological support, because parents are usually diagnosed depressed. They have a sense of guilt, so you have to remove that guilt. Many times in India, there are misconceptions that my daughter-in-law went outside when there was Grahan and she was cutting some chilies, and that is why this occurs during her pregnancy. So you have to explain them that they don't have to have guilt, and it is a nature which has resulted into this. You have to encourage them to continue with the pregnancy, and you have to assure them about treatable condition, and that is why we have serial photographs of these patients, and when we show them, they are extremely happy, and most of them, almost 99% patients in our OPD, they would like to continue the pregnancy. So you need to reduce their anxiety and prepare them to follow the schedule of cleft lip palate. There are certain feeding methods. There are specialized bottles. I will not go into details, but there are now available in market, and you can prescribe them. And this is a small video of breastfeeding video provided by Smile Train, and it explains that you have to feed them in a sitting position.
या तेज तेज दबाया तो दूध ज्यादा बहेगा और बच्चा उसे अंदर नहीं ले पाएगा। उस हालत में थोड़ा धीरे हो जाइए। अगर शुरू में ये ठीक से ना हो पाए तो चिंता मत कीजिए। थोड़े ही दिनों में माँ और बच्चा एक दूसरे से एडजस्ट हो जाएंगे। कटे हुए तालू
So this is how you can
को पिला सकती है।
you have to feed them with
कुछ
bottle
जगह ऐसे
in a
बच्चों को
sitting
दूध
position.
पिलाने के लिए खास बर्तन या खास बोतलें भी मिलती हैं। उनका प्रयोग भी किया जा सकता है। अगर खास बोतल ना भी मिले तो साधारण बोतल के निप्पल के सुराख को काटकर बड़ा करके काम लिया जा सकता है। लेकिन ये अवश्य सुनिश्चित कर लें कि इस्तेमाल में लाने वाला बर्तन या बोतल पूरी तरह से साफ और स्वच्छ है। इन्हें इस्तेमाल से पहले कम से कम 10 मिनट उबाल लें। ऐसा ना करने से बच्चा बीमार पड़ सकता है और उसके स्वास्थ्य को नुकसान हो सकता है। यदि किसी कारण से माँ अपना दूध बच्चे को पिला नहीं सकती तो गाय का दूध या बाजार में मिलने वाले डिब्बे का दूध भी पिलाया जा सकता है। ये माँ के दूध की जगह तो नहीं ले सकते, लेकिन अगर कोई और रास्ता ना हो तो इनसे काम चलाया जा सकता है। अगर बच्चे को गाय का दूध दिया जा रहा है तो उसे किसी साफ बर्तन में पहले पूरी तरह उबाल लें और फिर ठंडा हो।
So we show this video to all the parents, and then they are happy. So if you talk about surgical management, then it involves a multidisciplinary team approach with cleft surgeon, orthodontist, prosthodontist, speech therapist, ENT surgeon, pediatrician, psychologist, geneticist, nutritionist, social worker, and the nurse. So there are so many people involved into cleft care, and all of these need to work very sincerely. So there used to be experiments on in utero surgery, but it has remained in experimental phase even after 30 years of research, and still it is not possible. So if you talk about treatment schedule from birth to 4 weeks, main issues are basically parental adaptation. So you need to go for psychological counseling and genetic counseling. Feeding issue, I explained, and you have to rule out other anomalies and do a complete medical examination. From 1 month to 3 months, it is very important to stress on the feeding, because they have to grow normally, so they can be operated on time. And you need to do their nutritional assessment and provide them nutritional support. And then many people do nasoalveolar molding, but these facilities are not available at all Smile Train centers. So we also don't do it. But then we have a nutritional support. Now look at this child. It is so malnourished when it presented. So for nutrition, we have from Smile Train side 5-year commitment that we will provide all the things required. So if you see this child, this is a child which was malnourished. So we gave them nutrition, and then we operated, and you can see a very smiling baby, very smart, and the conditions they live in are really so miserable that they really can't afford to do anything. But we really thank Smile Train for providing these services. Everything is free of cost to these patients. In fact, to and fro is also free. So in nutritional assessment, what we look for are the Z scores. So Z scores are for weight for length, weight for age, length for age, and all scores should be more than -2, and then only child can be operated. If we especially see for weight for length and the score is less, then we give them nutritional support. And we are thankful our dietitian Ekta Kinger, she's associated with as a Smile Train nutritionist, and she takes care of them very well. This was the child which I showed you initially. We nutritionally supported that child, and you can see after the complete growth, she had a bilateral cleft lip and palate. Then we operated. You can see a beautiful result in this patient. And then we did so cleft lip repaired is around 3 months of age. Around 9 to 10 months of age, we do cleft palate repair. And you can see this beautiful girl smiling and very happy family. So 3 months we operate a cleft lip, and around 6 to 12 months we operate cleft palate. But we operate after 9 to 10 months because the children start speaking around that age. So monosyllables they start around 6 to 7 months, but then little words they utter after 9 months of age. So around 9 to 10 months we operate, so that when they start speaking, their speech apparatus should be normal. And this is a patient of left complete cleft lip and palate, and you can see a beautiful result, smiling girl. However, if you leave minor deformity in the childhood, that grows to a bigger this thing. So you can see her nose. When she became adult, she had a nasal deformity. So we operated her for rhinoplasty, and you can see this girl now. She is in 3rd year of college, and she's extremely happy family. You can't notice that she had cleft lip and palate. Another patient who presented to us, he had 24-year, operated elsewhere for cleft lip and palate, but he has this stigmata of cleft lip palate, and he's an engineer doing already job, but can't get married. So he came to us and we transform his. Now issues are, he had a maxillary retrusion, he's got depressed ala on that side, and he's got upper lip notching with the significant nasal deformity. So what we did the iliac crest bone graft for maxillary retrusion and with nose rhinoplasty. Then we did for a speech improvement, we did a pharyngeal flap surgery. So it improves the velopharyngeal port, and then they speak normally. We also did the upper lip notch correction. So you can see now pre-operative and post-operative. You can't notice that he had a cleft lip palate or he had a significant nasal deformity. A very smart boy, and he is extremely happy. You can notice that in his eyes that he's extremely happy after this. And this is his speech before the surgery.
माझं नाव सावदा, तालुका जावेर, जिल्हा जळगाव. मी इंजिनिअरिंग केलंय, डिप्लोमा इलेक्ट्रॉनिक्स मधनं. आम्ही कंपनीमध्ये IT मध्ये जॉब करतो मुंबईला.
So you can see his movement of the lip and the tongue. The lip movement is inadequate. The tongue movement, he's putting his tongue to the teeth to speak. And if you see his post-operative speech.
माझं नाव दिलीप विलास पाटील, राहणार सावदा, तालुका जावेर, जिल्हा जळगाव. मी बाय प्रोफेशन सॉफ्टवेअर इंजिनियर आहे मुंबईला.
So there is a significant improvement except the movement of the tongue, and we have given him the mirror therapy so that he is supposed to look into the mirror and speak properly, and he is going to speech therapist also, and I'm sure he will have completely normal appearance while speaking also. So my last case, I will show you the left complete cleft lip and palate in a girl, young girl, and at 6 months we did the cleft lip. Then this was immediate post-operative, and this is 17 years pre-operative when she came for a cleft rhinoplasty. At that time, we did certain minor surgeries for the lip correction also, and this is her post-operative result. And this is a beautiful girl. She is now engineer, and she has put a resume for her job, and I'm sure she will get excellent job. And if you look at her, she is excellent singer, and you can notice her speech.
के झोंके आज मौसमों से रूठ गए, गुलों की शोखे आज भौरे आके लूट गए, बदल रही है आज.
But then her mother was very devoted. She was taking so much good care, and she followed speech therapy schedule so well that we got excellent result in her. And this is the child which we have converted into a full-grown adult, and we have been with them from birth to almost age of 23. And we are also very happy to see our results like this. So let's build a strong nation by improving the cleft care in India, get these children in the mainstream society, make them independent, because unless we give them best of the result, they cannot become independent. And best service as doctor towards our nation can be by giving excellent result in patients. Thank you very much. And I again thank AMOX and Smile Train for inviting me and talk in this session. Thank you all.
Excellent photographs and outcome of patients, Rajendra sir. This
Thank you, sir.
encourages all those deformed kids and then adults to reach to you or such persons like you, so that they can correct the deformity. It's an excellent presentation.
Thank you, sir. Anybody wants to ask any questions? I'm there.
Sir, involvement of the hard palate and soft palates, does it makes any prognosis difference?
Yes, sir. Now,
Postnatal?
if you see in a patient with complete cleft lip and palate, even the hard palate and soft palate are completely divided. So they have a speech problem from lip to the soft palate. But in a patient who has got normal lip and a normal hard palate, and the hard palate is always notch, even if they have incomplete cleft. What we call it as the incomplete cleft of the secondary palate behind the incisive foramen. And they have notching on the hard palate, and this soft palate is completely cleft. In fact, if my experience and whatever is literature, these patients with incomplete cleft palate have poorer result because their palates are really short. And most of them, they have a velopharyngeal incompetence, and we need to do some surgery for velopharyngeal incompetence at a later stage when they are around 4 to 5 years of age. So because we want to give them surgical result when they can communicate with us properly, when they can communicate with the speech therapist. But the speech therapy starts around 3 years of age when the children usually start communicating.
Yes.
Hello.
Yes.
Dr. Sharad.
Yes, sir.
There is one question to you, that how will you take the consent that you have consulted on ultrasound anomaly?
Sir, I prepared one consent for the actual detection rate and the missing chances and the prognosis. All everything is mentioned in that, as well as I have two machines. One is Voluson and one is Logic V5. I also mentioned the machine also on which machine I perform the sonography. And after counseling, I took the sign of the patients and I keep the two copies, one copy with me and one copy I hand over to the patients. And everything is mentioned in that. Even normality is not means 100% normal. What are the limitations? What are the genetic causes? Everything mentioned in my consent, and I give before calling patient. If patient is in waiting room, I give that consent to read to the patient and their relative.
So you had different consent for that.
Yeah, I have different consent for growth scan. I have different Doppler, 2D echo, NT, because every scan has its different meaning. So I kept that different.
So it will
Even
be
for
beneficial
TVS
to.
and P, also the TAS and TVS also mentioned in that consents, because the ideally if cervix is not taken by the TVS and if you are done by TS and later on patient aborted after the anomaly scan immediately 2-3 days back, the TS will not support you. TVS scan evaluation cervix is always supportive in court. So that also mentioned in that small things are mentioned.
So at this platform, can I ask you to share that consents so that all the Amox family doctors will get benefited from this? Those
Yeah,
who
I
are
will
doing the
share
ultrasound.
tomorrow in group. Okay,
Right.
it's okay? Yeah.
Yeah. Thank you so much, Sharad.
There is question in the chat box by Dr. Sood. Is speech therapy required for a cleft lip and palate all patients? So almost all patients are subjected to speech therapy after the age of 3 to 3.5 years. And as per their speech deficiencies, we try to correct their deficiencies. So there are certain minor deficiencies which can be corrected by speech therapy. Some of the deficiencies, they need good surgical care, even secondary surgeries like alveolar bone grafting and having a tooth in place, or doing surgery for velopharyngeal incompetence. That is one. And she's asking again when the rhinoplasty is done. So rhinoplasty is done after the age of 16 to 17 because the facial growth is complete after the age of 16. So normally in girls it is 15, 16 years. But in India, the 11, 12th standards are so busy for them that we normally advise them that once you pass out from 12th standard, then we will do the surgery.
She told me I to the doctor if my heart hurts. My friend told me I've fallen in love. He says, "What nonsense is this?"
Hello.
Yes, there was some disturbance.
Yes, sir. Continue.
So the rhinoplasty is done normally after they pass out the 12th examination. And before that, many of the children come, so I talk to them nicely, explain them, and then I insist that if you get good marks, we will do a better surgery for you. So they have to essentially get good marks in 12th standard. So it becomes motivation for them.
For this cleft palate isolated things is there, and the workup for the genetic is not done. Whether you do the genetic workup before reconstruction surgeries for the prognosis point of view?
Yeah, for the prognosis point of view, if the parents are interested, then yes, we do. But most of the time, parents are not interested, and it doesn't affect our surgical care because on clinical examination, we can see the other anomalies also. For research purpose, yes, at certain centers, the research are going on, but it is not possible not possible for everybody to go into the research of etiology and their proper genetic testing and classifying them properly. So it is only being done at a few of the research centers.
Yes. Dr. Sharad. Hello.
Yes, sir. Yes, sir.
Dr. Sharad, the question is that how will you counsel if the patient is post-delivery, the baby developed breathlessness because of diaphragmatic hernia? Because in the anomaly scan, the scan was showing normal, but then after birth, there is a dyspnea and the patient on the further investigation, it is found to be a diaphragmatic hernia. So in such patients, how do you counsel the parents?
It is if you miss the anomaly and it is detected postnatally and immediately it get diagnosed, it is very difficult. It requires the balance counseling by the team of the obstetrician who is giving care and pediatrician who is managing and pediatric surgeon who is giving the treatment. Because if the prognosis is good, there is less litigations. And if its prognosis is bad, then it is very difficult to counsel these patients, and you have to accept and counsel patient that this anomaly miss and reason for missing, because sometimes the posterior herniations they are usually missed in diaphragmatic hernia cases, or the sometimes even bowel herniation also miss. If stomach is at normal position or small and only the small bowel is herniated, or the diaphragmatic diaphragm deficiencies is there, in that cases there are the high chances of missing. Otherwise it is nowadays with advanced technology it is very not that much common to miss the diaphragmatic hernia. But any anomaly miss, it is difficult. It required the balanced counseling of obstetrician, pediatrician, and the treating surgeon is required for this cover.
So
if you have any miss or our colleagues has done any what it call as loose comments against anyone, then it will be create the litigation, and that is one of the major cause for litigations. So you have to contact with the person who referred and that and tell them what are the limitations for the missing, why it miss anomaly, and that parents and the relative counseling session with three of these people, then it is easy to accept the things.
That is the leading question that parents ask, why that radiologist missed the diagnosis. So how to counsel in that way? That is what particular answers that vernacular language you can
Then we
tell us.
this thing happens. We evaluate if the images are there, whether he has taken proper views or not, whether there is any position issue, whether any maternal or fetal factor is that. Then we consider that, and then according to that factors, we will counsel the patient about these missing things.
So, which person to blame?
Nobody can blame.
No, it is
Yes.
again. It depends upon the how much your
Right.
relations with these peoples.
So,
And I always telling everyone that not anomaly scan is not only the scan to do the detail evaluation. URI scan should be done in that way because
right.
the most of the times this evaluating anomalies might be detected in future scan, and it happens when the obstetrician doing growth scan and only referring anomaly scan to the radiologist, and if radiologists are not doing a proper scan, then in that scenario there are high chances of missing.
Right. Right. So to conclude, I would like to give the closing summary that medicine is not a perfect, and we must continue to educate ourselves and our patients about
Yeah.
the realistic limitations of the imaging technologies presently available. The detection
Yes.
of non-lethal anomalies remains a significant challenge.
Yes, sir.
Communication is our strongest defense and our greatest duty. From the initial consent for the scan to the delivery of the unexpected news, how we communicate can either build a bridge of trust or burn to it down. A misdiagnosis handled poorly becomes a lawsuit. Handled well, it becomes a shared journey of care for a child with unique needs. So let's create a environment to have a 100% empathy rate with the parents and the born baby, and this will definitely save all of us from the lawsuit. So
Yes,
thank you,
sir.
Dr.
Absolutely.
Sharad, Dr. Rajendra sir, for enlightening us. Thank you, Dr. Monica Madam, for giving the opportunity. Hello.
Thank you, Sharad sir, and thank you, Rajendra sir, for joining us for an enlightening session today. I would also thank Dr. Kiran Kurtukoti, Dr. Bipin Pandit sir, for allowing us to conduct this under the AMOX banner. Science Integra and Smile Train for giving us the academic grant and for persistently being with us and conducting these webinars through the last 4 years. Thank you, Dr. Supriya Arwari and Dr. Madan Kamre for being the co-convener and the master of ceremony. Hedzi, thank you so much for the entire technical platform and the help. Sharad sir, it was an eye-opener. If you could also share the consents on the AMOX group, it will be
Yes,
really,
yes.
really helpful for all of us
Yes, sir.
also
Definitely, I
Yes.
will.
who are doing this. Supriya ma'am, do you want to add something?
No, just a thank you to all of you. Wonderful, really sense. And you feel only one pick flip palette. What is there to learn? But every session there is something new to learn. Really, thank you to both the speakers. Thanks to Hebzi and the entire Smile Train team, and special to Nika who. Thank you, Monica. Over to you, and then I think we can wind up.
Yeah. Thank you so much, everyone, for joining us today, and have a happy weekend.
Thank you,
Thank you,
Nikade
Hedzi.
sir.
Thank you,
you.
Supriya
Thank
Madam.
you.
Thank you.
Sir, wishing you all the very
Thank
best
you.
for the future elections in
Yeah.
Foxy as the committee chairperson, and wishing Madan also all the very best.
Thank you. Thank you so much, madam.
Thank you, sir.
Thank you, and bye bye. Take
Bye
care,
bye.
everyone.
Thank you.
Thank you.
Thank you. Bye.
Thank you.
Tech team.